Welcome to Bioptická multi-head slide seminar. Marián Švajdler speaking as the first presenter. And I've got a couple of interesting rare cases and some textbook examples of common but nice biopsies. My first case is older male patient, and this is a biopsy from urinary bladder. And as you can see, the tumor has got this exophytic papillary component, which is something between grade 2, maybe grade 3. So I called this non-invasive papillary urothelial high grade or grade 2, according to that old classification. But in addition, so this is the exophytic part, but in addition there is something more there under the surface epithelium, and you can see quite atypical looking cartilage, even with some mitotic figures, not many, but they were there. And some pinkish stuff also, some matrix. Maybe it's more here. Quite atypical looking spindle cell proliferation and making this eosinophilic matrix. So the spindle cell component is of course SAT-B2 positive because these are malignant osteoblastic cells, and this pinkish stuff is osteoid. And together, this is a picture of chondroblastic osteosarcoma. So unfortunately, my explanation for this is that we have this non-invasive papillary urothelial carcinoma, and there is somewhere else, not included in the biopsy, invasive urothelial carcinoma, which eventually differentiated into this malignant sarcomatous component in the form of chondroblastic osteosarcoma. Because otherwise, chondroblastic osteosarcoma is nonsense in the urinary bladder, but in contrast, urothelial carcinoma may show sarcomatous differentiation and sometimes even heterologous differentiation in the form of osteosarcoma or some other kind of sarcoma. So this is the differentiated sarcomatous urothelial carcinoma, essentially. And this was consult case, and I've never seen such heterologous differentiation in urinary bladder cancer. My next example is old lady, and she presented with subcutaneous tumor in her thigh area, and we saw this tumor type several times, so it's quite easy, but it's this largely necrotic tumor with this heavy crash induced changes. These artifacts, and should look into the better preserved areas to see the cytology. Okay, so it's
What's the location again?
It's subcutaneous mass.
And where?
Thigh or it's old female.
Small cell carcinoma.
Yeah, it looks like small cell carcinoma, but we are in the skin. So it's particular. So this is cytokeratin 20, which will give you this very nice, typical perinuclear dot-like positivity. And already with this antibody, you know the diagnosis, right? It's Merkel cell carcinoma. So the tumor was diffusely positive for synaptophysin, and Ki67 was essentially 100%, and chromogranin was negative, and there was some Merkel cell polymavirus positivity. So it's Merkel cell polymavirus associated Merkel cell carcinoma, small cell carcinoma, neuroendocrine of the skin.
You might have 1 week now.
Yeah, it's not that uncommon lesion, and you should do the right diagnosis because it's quite aggressive lesion. And there are at least 2 types of this cancer. One is associated with the virus, and the prognosis of this type is, I believe, a little bit better compared to not associated with polymavirus. Next case, it's again older lady. It's axillary skin biopsy, and the case was sent in consultation. And you can see already in this very low magnification something interesting there. We see epidermis, and there is some epithelial proliferation within the epidermis. And if you are not sure, you can do immunohistochemistry. The cells were negative for melanoma markers, positive for epithelial markers, including cytokeratin 7. And it's female, and it's in axilla. So we stain for estrogen, progesterone receptors, gross cystic disease fluid protein, and some other breast cancer markers. Everything was positive. So it's extramammary Paget's disease. But in addition, I didn't show you the second component of it. You've got something here under the surface in the dermis, and it's invasive carcinoma. According to imaging studies, there is no lesion in the breast. Okay, so they did everything to prove it's metastatic from the breast, but it's not. So in this instance, I call this extramammary Paget disease with associated invasive carcinoma of mammary type.
It will be ectopic. Mama, probably.
Yeah, but I didn't see ectopic, but it may be overgrown by the tumor. Okay. That's another possible explanation. So it was sent with the diagnosis: is this a strange skin adnexal carcinoma with Paget spreading? But I think it's not. It's mammary type carcinoma. Okay, my next case is an easy one. It's again a subcutaneous biopsy from the neck region, which is a typical location for this tumor type. And already in this very low magnification, you can tell that it's probably lipomatous tumor, and shows these funny looking, we call it florid cells, which have very hyperchromatic, ugly looking nuclei, but there is no mitotic activity there. and you got this typical collagen pattern there. And if you will search for lipoblasts long enough, you will probably even find some lipoblast there.
On first sight.
Yeah.
Not long enough. On first sight, see everywhere.
Yeah. It depends what kind of cell you call lipoblaст, but yeah, I agree. There are some of these. So, any suggestions from the youngsters here?
This genius of Singer, he recognized it in 1960. Can you imagine? He recognized it 85 years ago. Yeah, that it's benign lesion. Yeah.
It's benign lesion. Okay. Yes. You should not call it atypical lipomatous tumor. And if you wish to perform immunostains for these, you should do CD34, and the lesion is diffusely
And RB1
CD34 positive. Okay. And also you can do your retinoblastoma protein study, and got retained expression in some stromal cells, endothelia, maybe some lymphocytes, and
lymphocytes on that.
loss of expression in the tumor cells. Okay, and it's
the possibility
pleomorphic
is
lipoma.
in endothelias and lymphocytes.
Yeah.
The tumor is negative.
Tumor is negative. So it's pleomorphic lipoma.
Yeah.
So it's benign. Okay. My next case comes from the CNS. It's meningioma. Which showed two types of histology. One of these was this, we call it microcystic meningioma, with these very small microcystic spaces here. It's almost lipoblast-like cells. And the second component was regular meningothelial meningioma, but it's not this very well differentiated, but it's rather hypercellular and grows in diffuse sheeting pattern. But in addition to this hypercellularity and diffuse sheeting growth pattern, there were no other atypical features. So in these cases, you should do you should do you should do additional testing according to this C-Impact Now Update 8 on clarification on molecular risk parameters and for WHO grading of meningiomas. And in situation, we are in this situation featured borderline between grade 1 and grade 2, because we've got 2 of the 5 so-called soft criteria for atypical meningioma. So we have performed copy number variation analysis, and in this case we had 1p and 22q chromosome loss, and based on that we can tell that this meningioma goes into the grade 2 category, so it's let's say intermediate risk lesion, just based on molecular, not on morphology. So I will include this paper on our web pages, and it's also, I believe, freely available on the web. Okay. And yeah, maybe one one immunostain for this case. This is histone H3, K27, 3 methylated form. And you can see that there is retained expression in the internal control in the endothelial cells. And it's diffuse loss of expression in the tumor. There are studies confirming that meningiomas with loss of H3, 3 methylated form expression are higher risk. So this somehow confirms the molecular findings here. Okay, so right now it's present somewhere, but mainly lost. This is something we do regularly for all meningiomas right now, like a prospective kind of study, but I'm not sure whether it works really. Okay. My next case is again, it's let's say middle-aged adult patient with a brain tumor, sent in consultation. I don't know the location, nothing. It's some micro calcification. They did ask for the diagnosis because they were not sure about the diagnosis, and when I looked at the tumor, I was not sure either. It looks low grade. No big atypia, no mitotic figures, no necrosis, no microvascular proliferation. It looks a little bit astrocytic here, but maybe here some architectural arrangement, and in other parts, maybe in the slides. Second. Here. It looked quite oligodendroglioma-like, even with microcalcifications, but the tumor was IDH1 and IDH2 gene wild type, so no mutations. So it's not oligodendroglioma, okay? So we have performed methylation profiling. This Heidelberg classification, which is now called epignostics, and it came back as a low-grade glial neuronal neuroepithelial tumor category, and the first subcategory was Dysembryoplastic neuroepithelial tumor. So I agree that the morphology is consistent with this category. This is low-grade benign lesion associated with chronic drug-resistant epilepsy, mostly in children and very young adults. This is a little bit older person involved, so this even confounds the diagnosis of this tumor type here. And morphologically, it does not show this very typical specific neuronal component, which is diagnostic of the tumor, and rather shows alternative or variant morphology, which is called diffuse morphology. Not everybody agrees with the histomorphology of this diffuse type, but I've seen 2 or 3 cases right now confirmed by molecular studies. These tumors show alterations in MAPK pathway, most commonly FGFR1, gene alterations, mutations, fusions, amplifications maybe. or internal tandem duplications, and some other, including BRAF and some other changes. We didn't perform molecular studies, but they probably will ask for that later. So this is example of CNS tumor type that is essentially impossible to do the diagnosis without methylation profiling based on morphology only. Okay, the next case is quite interesting. It's a middle-aged female, and she presented with paraspinal thoracic tumor mass, quite big. It was sent many fragments, and they measured maybe 25 centimeters in biggest diameter. And there was one important information. The patient has got neurofibromatosis type 1 syndrome diagnosed. So even before looking at the slide, there is some kind of differential diagnosis running in my head. Such a big tumor in NF1 patient. Okay, so we see the spindle cell proliferation, which does not show this typical neurofibroma morphology, because clinical diagnosis was neurofibroma. I cannot imagine 20 or 30 centimeters big neurofibroma in thoracic cavity paraspinal location in NF1 patient. Okay, it's nonsense. Although some areas were less cellular and less atypical, there is some atypia. Importantly, there were quite many mitotic figures, and necrosis was focally present. And this case nicely demonstrates morphological patterns of MPNST malignant peripheral nerve sheath tumor. Not all of these show this very monotonous sarcoma-like morphology, but some of these may resemble solitary fibrous tumor, for example, or Tenosynovial sarcoma, for example. Typically, this is SOX10. You will get some SOX10 positivity, but it's never diffuse in MPNST. It's this focal at most. The similar pattern of immunoexpression was present for S100 protein. And again, we've got histone H3, K27, 3 methylated form. And you can see it's almost completely negative. There are parts completely negative and some parts with a little bit of retained staining, but it's still nice loss of expression for MPNST. So this is MPNST in patient with neurofibromatosis type 1 syndrome. And there is quite a new paper out there on peripheral nerve sheath tumors arising in the setting of NF1 type syndrome. There are some updates on these tumors. Importantly, the category of so-called low-grade MPNST was abundant, and instead we have atypical neurofibromatosis neoplasm of uncertain biologic potential with increased proliferation instead. And the reason is that we still don't know how these atypical tumors behave. Most of them behave in benign manner, so are not aggressive in contrast to MPNST. So they omitted like the name low-grade MPNST to avoid over-treatment in these patients. So in addition, we've got some molecular criteria how to put these atypical and malignant tumors into correct categories. So the presence of CDKN2A inactivation puts the tumor into the atypical neurofibroma category, and we've got some mutations which will automatically put the tumor in the malignant category as well. So,
it's important to remember that this category or this table is for patients with NF1 syndrome. Sometimes if tumors big like this and you have enough blocks, you may see areas where there is conventional neurofibroma and areas where it transforms into this atypical neurofibroma, or now we have this beautiful term NUBP. Then it can transform further into an UBP with increased proliferation, and then you can have areas like MPNST. So we can have the whole spectrum in one sample. So that's in patients with NF1 syndrome. If the patients don't have NF1 syndrome, you can also have MPNSTs in these patients, but they typically arise de novo. You don't see this transformation from the lower grade areas.
I think that important addition to these classifications is inclusion of the molecular techniques, because nowadays they frequently only biopsy the tumor in NF1 patient, and it's important to do the molecular studies on these small biopsies to avoid like false categorization of the tumor, either benign or malignant. Okay, so this genetics works for biopsies, because if you've got resection, like in my case, it's not that problematic, because I was able to find like hypercellular, metabolically active and necrotic parts, and it was straightforward MPNST in my case. Okay, so we'll move to my next case, and this is a historical case. It was consulted here 12 or 13 years ago, and at that time it was categorized as a myoepithelioma, soft tissue, and molecular studies at that time showed only EWSR1 gene break, but no fusion partner was found at the time. And H&E is not very nice here. It was probably something wrong with the biopsy in the referring department, but we can see it's something set in myxoid stroma with this trabeculae of roundish cells, and these 13 years ago showed some EMA positivity and S100 positivity. And the tumor came back, and it's quite big mass on the shoulder. It's female, no, it's male patient, 43-year-old, and maybe
Extraskeletal myxoid chondrosarcoma.
Yeah, it's extraskeletal myxoid chondrosarcoma based on molecular studies.
What is a fusion partner?
It's the typical fusion partner is NR4A3 gene, very typical. Okay, so we have spoken about so-called myoepitheliomas of soft tissue here several times. and it's probably very heterogeneous category of tumors, and I believe that some of these tumors previously classified as myoepithelial tumors or myoepitheliomas or myoepithelial sarcomas of soft tissue probably will go into the category of extraskeletal myxoid chondrosarcoma, because you cannot distinguish between them by immunohistochemistry. So molecular studies are needed here.
At that time it was excellent diagnosis, now it is even better diagnosis.
Yeah, it's wastebasket. And yeah, my last case, it's very easy. Easy one. Probably. Yeah. So it was a tumor of the knee joint. It's very easy. Involving synovium and destroying the knee joint.
Diffuse.
You can see this mononuclear, quite monotonous looking cells. Some are pigmented and it will be hemosiderin. No mitotic figures, no big atypia, and in addition to this component, this is some multinucleated giant cells, not very frequent here in this example. They are there. And there was one interesting thing I never saw. This big vessel with some exogenous material. So they tried to embolize the feeding arteries of the tumor, but it didn't work because it's still alive. So the diagnosis is Tenosynovial giant cell tumor. In this example, it's so-called diffuse type because it's diffusely involving the joint and even destroying the joint. And it didn't show any signs of malignancy. So still, you may have this so-called benign tenosynovial giant cell tumor and still may give rise to metastatic deposits in the lungs. So previously this lesion was called pigmented pilonodular synoveitis, but it's not longer recommended. Okay, that's it.
So good afternoon, this is Květa Michalová speaking. I have 5 cases, especially the first 2 are very easy routine cases, and the following 3 are not so usual, but you will see. So the first case is the corporal polyp of endometrium, somewhere here. The age of the lady is 68 years old, and as you can see, this is a typical type of corporal endometrial polyp. Sorry.
Yeah.
So you can see the typical appearance of atrophic type endometrial polyp. And in this area, this is a little bit different. And you can appreciate here sorry. You can appreciate here high-grade cytological atypias.
Serous carcinoma.
Yes, it is serous carcinoma arising in the polyp, and the take-home message here, especially for the residents, is that every time you have very typical lesion of corporal endometrial polyp, especially in older patients, there can be a probability of some malignancy arising in the setting of otherwise typical atrophic type of the polyp, and the malignancy can be either endometrioid carcinoma or serous carcinoma or other types of Müllerian derivated tumors. And if you are not sure which type is it, you can, for example, use besides morphology, also P16. Here it is diffusely positive in P16. In case this was P53 was also positive. This is P16, and it would be typically not so. I'm sorry for the focusing, but now it works. So diffuse positive for P16 together with over aberrant expression of P53, which is here. So this is serous carcinoma arising in the background of atrophic type of corporal endometrial polyp. You can also have here endometrioid carcinoma, which can also arise in the setting of endometrial polyp, but typically there is hyperplasia transforming into previously called atypical complex hyperplasia or endometrioid intraepithelial neoplasia, and then in this setting you can also see the carcinomatous component, and for serous carcinoma it is more typical to arise in the background of atrophic type of the polyp. And the older is the patient, the high probability of this atrophic type polyp and this type of carcinoma.
So endometrial polyp is 2-second diagnosis, okay, but you should always go through the surface of the polyp to rule out.
It's usually metastasized through fallopian tubes.
Yep.
It doesn't have to invade anything. Yeah. I saw a case with 2 glands, only positive for serous carcinoma, and killed the patient. Yeah.
So it's important not to miss the diagnosis in the polyp.
You have to always very carefully go through the whole lesion. The second case is also quite routine and easy. This is a liver biopsy from a younger patient. Younger patient, 30-year-old patient, and this is the lesion. It was biopsied as a lesion of the liver, not diffuse process. And this is quite frequent diagnosis, and it is characterized by the nodular appearance of otherwise normal, or at least structurally normal, sinusoids of the hepatocytes, and there are intersecting thick fibrous septae, very typically containing these thick walled arteries, like here. Does anybody from the residents have idea what the diagnosis is? Once again? FNH? Yes, FNH. Focal nodular hyperplasia is the diagnosis. The helpful thing is that it looks like cirrhosis, only it is local, it is not diffuse, and you have to know from the clinician that this is a focal process, this is a lesion, and it is not considered neoplasia. It was confirmed that this is polyclonal process, and this process follows some damaged process in portal vein, and it is considered as a local regenerative hyperplastic process. And if you want to differentiate this from I don't know, cirrhosis or whatever, you can use some immunohistochemistry. And this staining, it is the most helpful staining in diagnosing FNH. Does anybody know from the residents which staining is this?
Glutamin synthetase.
Yes, it is glutamin synthetase. Resident. It is glutamin synthetase, and glutamin synthetase has very, in focal nodular hyperplasia, it has very typical staining pattern. It is called map-like staining. It means that there are some areas of negativity and in the neighborhood areas of positivity, like here, for example. In a normal liver, in a non-neoplastic normal liver, the glutamin synthetase is supposed to be negative, or there can be only perivenular positivity, very thin rim of positivity surrounding the venous structures. And if you have malignant tumor, you have diffuse glutamin synthetase positivity typically, and this map-like staining is typical for FNH.
Just by looking at the microscope, I can tell it's probably female.
It is female. It is very typical for females, a 30-year-old female.
Because it's very unusual to have FNH in male patients. It's not impossible, but typically it's like quite young female.
Yeah. This was very young female. It was 30 years old female, and the typical age range is 30 to 40 years old. So a typical presentation. Then we have another biopsy. It is 48 years old man, and it is from funiculus spermaticus. And this is not a routine biopsy. This is biopsy diagnosed by you, Michal. And here we have only mucinous material in the funiculus spermaticus and some.
It's from Brno, yeah, the case.
I don't know, it's from Brno. I couldn't appreciate that this is from Brno from the picture, but you know better. This is a typical Brno patient. So here we have just mucous material with some inflammatory cells, but there were no epithelial structures throughout the lesion. Some hemosiderin here, inflammatory cells, and that was it. So if we have something similar in the ovaries, it would be more straightforward to think about the differential diagnosis, but in principle, this was the case here. So it was confirmed that this was mucinous material because it was pus positive and mucicharmin positive. It was also confirmed that there is absence of epithelial structures, and Michal made a diagnosis of Pseudomyxoma, in this case Pseudomyxoma funiculi, and suggests to clinicians to exclude mucinous tumor of the appendix, going in the same process as it usually goes to ovary. In this case, it spread it to funiculus spermaticus. I think we have one more case in our registry.
They operated the patients.
And the patient had
I opened the abdomen. They told me up the abdomen, and there was a cake of mucus around appendix, and they said, how they knew it. They are magicians in Pilsen, yeah? How they knew it that we didn't see it here, but they knew it from microscope in Pilsen, 300 kilometers away, yeah? That's funny. They called me and expressed that we must have some sage ball here to.
Yeah. So this was Pseudomyxoma funiculi, and the patient had mucinous tumor of the appendix spreading into the funiculus spermaticus.
Jste upadli na kolena, prosili upřízeň.
This is an old case, and it was included in our.
Ten years at least, yeah?
It is from 2018.
What?
2018. The year of the diagnosis was 2018.
2018, yeah.
Okay. Another case is from the testes, and the patient was 74 years old, and they sent us 3 tissue blocks of the tumor, which looked everywhere like this. So even in low magnification, we can appreciate that this tumor is malignant. If we use higher magnification, we can even more clearly see that this tumor is malignant. But otherwise, there are no specific features of any tumor known from the primary testicular tumor. There were multiple tumoral necroses, and it looked in all available tissue blocks the same. So this highly pleomorphic, very basophilic necrotic tumor. So very brisk mitotic activity, which you can appreciate in this field, for example. And as for immunohistochemistry, many markers were performed, all of which were negative, including lymphoma markers, including germ cell tumor markers, including sex chromosomal tumor markers, for example, SF1. Everything was negative, and there was a history of the patient written, and the patient had prostatic carcinoma, and so the prostatic markers were performed afterwards, and this is PSA. Some control. To find it, but this is control. This is the tumor, which was completely negative for PSA. Another prostatic markers. Do you have any suggestion, or younger audience, part of audience, which other markers would you use for prostatic origin?
NKX 3.1.
Yes, NKX 3.1. This is it, and it was negative as well. And also androgenic receptors, they're also negative. So prostatic markers were negative, and then we have one positive marker. And this is synaptophysin, very strongly diffusely positive. Then we have another positive marker. This is also neuroendocrine marker, but it stained in nuclei. Do you know what this marker is?
INSM1.
Yeah, INSM1. Also diffusely positive, and then NSA was positive. Neurospecific analysis was positive, only faintly, but there is some positivity. This is not the best marker, but still we can appreciate some positivity. The diagnosis of this tumor was prostatic carcinoma, but so-called treatment-related prostatic carcinoma, which is prostatic carcinoma after androgenic deprivation therapy, and these carcinomas typically they transdifferentiate into neuroendocrine small cell carcinomas or neuroendocrine carcinomas in general. They can be also large cell. They lose the immunoreactivity for typical prostatic markers, and they gain reactivity for neuroendocrine markers. These are very aggressive tumors, which for sure logically do not react anymore for anti-androgenic therapy, and they are very biologically unfavorable. So the diagnosis here was a treatment-related prostate neuroendocrine carcinoma. Metastatic to the testis.
You guys remember when we spoke about tumor plasticity? This is a prime example, post-treatment change. And now we have this new antibody for like 1 week.
Yeah, it's ordered, but
okay.
I don't.
There is a marker called HOXB 13
sorry.
or 18. I don't know.
13.
13. HOXB 13, and it should stain exactly cases like this. Prostatic carcinomas which are negative for prostatic markers and have neuroendocrine differentiation.
Yeah, you will see how this works, this order. And my last case. My last case is tumor of the ovary. I have to find it first here. Tumor of the ovary, 52 years old patient. Looked like this. In this area, it is an overtly malignant tumor. In this area, it has morphology of endometrioid tumor, endometrioid carcinoma. But there were other areas with more solid morphology. For example, here there is more solid morphology. And in other blocks, most tissue blocks here had the solid and endometrioid morphology. But for example, here I have some circle, I don't know where. This is also solid morphology, but if you have some imagination, you can imagine that this can also resemble, at least distantly, urothelial morphology. So this pattern of growth is called, in abbreviation, SET, solid endometrioid and transitional morphology. And it was found out that this kind of morphology is very typically associated with underlying BRCA2 germline mutation, which was also the case in this patient. So this morphology of ovarian tumor, solid endometrioid transitional, can be used as a morphological indicator of underlying germline syndrome of BRCA mutation.
Important for treatment of the patient. Yeah? Important for treatment of the patient. Yeah. It's a mistake to miss it.
Yeah, sure. We need to have validation of underlying molecular alteration, and also to examine families and put adequate treatment to the patient. Okay, that's all from my side. Thank you.
Okay, I have just a few cases, 2-3 cases. Michael Jr. speaking. This last case, or this next case, is a 32-year-old male with a tumor on his chest, somewhere in the midline. The clinical diagnosis was a cyst. So clinically, it was thought to be a cyst, and this submitting pathologist sent it with a diagnosis of a vascular neoplasm of unknown potential, and this is what we had. Let's maybe one more slide. Just very small pieces. This is better. Very small pieces of tissue. So there is some adipose tissue at the periphery, some fibrous tissue more in the center. Theoretically, this looks a little bit like a vessel wall. And we have some hemorrhage here. And right next to it, basically transitioning from the forming thrombus, you have this vascular lesion. And if you go on highest power, cytologically it's a little bit hyperchromatic, but no major atypia, no mitotic activity either. Any suggestions what this could be, or what would be the differential here? Anybody? Not only the residents?
Hemangioendothelioma.
I'm sorry?
Hemangioendothelioma.
Hemangioendothelioma? It's in the differential, hemangioendothelioma, or angiosarcoma, or since we have the thrombus here.
It's Masson tumor.
Yeah, the so-called, I think this is a so-called Masson tumor. Today it's called papillary endothelial hyperplasia, and it's basically a form of thrombus organization. So basically, thrombus forms, and then as it's recanalized, the vessels sometimes look this worrisome, and it mimics angiosarcoma basically. And obviously, it's a grave mistake to call it angiosarcoma, because that's a very high grade tumor.
It's tumor. It's tumor. You have MIB1?
Yeah, I have MIB1, and there's basically 0. Here's Ki67. It's not the part. Here it is. So if it will be angiosarcoma, I mean, don't rely on Ki67 in soft tissue pathology, but angiosarcoma would be through the roof. It would be 100%. And so papillary endothelial hyperplasia. I think we are out of time. Okay, so I guess we meet next week, right? Next week on Tuesday. See you or hear you again. Bye bye.